It's my belief that there hasn't been enough work done on implementation. So it's fine to have some measures or some metrics around outcomes, but actually we need to know how to make them work in practice. So we have a project which is called OACC, the Outcomes Assessment and Complexity Collaborative, which is about service development rather than research. It's about trying to understand how we look at evidence around outcomes, how we make them work on the ground, and what does work and what doesn't work. And it's that learning that's really driving forward some of this, and that's the gap which hasn't really been bridged very effectively. So OACC is a collaboration across South East London. It's funded by the Guy's and St Thomas's charity, who have the vision for this. And it's about developing the necessary staff training to support the implementation of outcome measures. It can't just happen by some alchemy that, you know, one hopes happens. There's actually quite a bit of work to do around it, which I'm sure you know very well. It's also about integrating health information technology to establish workable ways of capturing and processing data. And the teams we are working with go from paper only to up to a complete integrated IT system and everything in between. It's all possible. It's just finding the solutions. And then the other bit which I think is key for me, which is regular feedback of results to the teams using a role that we have pioneered following the Australian model, which are quality improvement facilitators. And these are people from a nursing background or other clinical background who can actually work alongside staff to help with the implementation and help feed back measures that are captured to help drive better care so that they mean something to the clinicians on the ground and they're not just data to feed the beast. We're extending it across London and nationally, and it's very much a partnership, as Heather has described, with a variety of key partners, with Dr. 𝐒𝐓𝐷𝐇 very much engaged in this at national level, NHS England and Public Health England, the funding pilots, which I'm sure you'll want to hear more about, and other partners. And it is an open collaborative. We don't want to be a clique or a separate group. It's open to engagement from all of you and other organisations, and we want to ensure that it stays that way. I would also mention the clerk. For those of you who don't know what a clerk is, the National Institute of Health Research, which is the research arm of the NHS, has recognised the difficulty of getting research across the gap into practice. And they have set up around the country something called a clerk for every area, which means collaboration for leadership in applied health research and care. And actually what that means is getting evidence to inform service development and making it actually work on the ground. So this is very helpful for us because we have a South London clerk, and it has enabled us to take the work from OACC, which is in South East London, and share it with partners across South London. And actually we're being reasonably inclusive in our definition of South London. It's also very much connecting in it's also very much connecting into the national work, and that's the idea of clerks, is that they don't stand in isolation but they connect up. So our short-term objectives are to identify a common set of measures to capture patient needs and outcomes, and they're measures that have to work hard for us. So they have to do several things. They have to tell us about the patient's needs, they have to tell us about the complexity of that person's needs and maybe their family's needs. They have to tell us about the outcomes, and I'm going to define outcomes in a minute, and they need also to deliver to quality indicators. Now, I am very much of the belief that we should just have one set of things to collect, not 16 sets of things to collect. So we shouldn't be collecting something for our annual report, something for the clinical service to understand what it's doing, something for the minimum data set, something for the tariff, something for 𝐒𝐓𝐷𝐇, and something for everything else. It just is not feasible, it's not practical, it's not sensible. We need one set of things which will do everything. And I'll talk a little bit about what everything includes and what might be outside of the everything we're talking about today in a minute. In the medium term, we want to implement the measures. That's a tall order, but that's what we're trying to get to, and work towards linked and pooled outcome data. Linked to other data sets where possible, such as, for example, modified voices data, or death registration data for an area, and so on, hospital episode statistic data. That's where we're trying to move towards, but also linked in the sense of different organisations in a sector. What that will mean is we can understand better population needs and outcomes, and that's really where commissioners want us to get to, because they want to commission for their geographical patch. To support also the evaluation of interventions, because if you think about it, if you've got valid and reliable outcome measures, you can actually tell whether a new intervention you introduce or a new service you introduce is actually delivering what you want it to deliver. To support quality improvement and to enable realistic and meaningful benchmarking. Now, normally when I say benchmarking, everybody's kind of the bristles on the back of your neck stand up and you think, oh, that's the bit I'm worried about. And I think that's right. It is an absolute chasm which potentially we could fall down, because benchmarking is coming because of the way health services are evolving towards outcome-driven healthcare, and because of the financial constraints on health services across developed countries, including our own, with a projected 25% cut or deficit in what we're going to be able to spend in our health services. So there's a chasm there where we could fall down around benchmarking, and that would be if we had benchmarking imposed upon us externally in a way which did not make sense for palliative care. What we need to do to avoid that is to take hold of this as a specialty and apply case mix adjustment, which means that variation happens in the health service because of the patients or because of what's being done to them by the services. And actually, we need to understand the variation because patients are different to adjust for the differences that are actually variations between services. And that is case mix adjustment. And we need to get that right for palliative care, and we're working hard to try and achieve that. So I am all for realistic and meaningful benchmarking, but only when we know and understand how to case mix adjust properly in palliative care. So that if one service sees older people or more complex people or different ethnic mix or whatever, we can understand what that will mean in terms of the outcomes they can achieve. And the long-term objective would be to regularly map case mix adjusted outcomes across settings and services of similar type to support quality improvement. And the bottom line in all this is we are driving for better care for patients and families. That is the primary aim. And all those other secondary aims are important, but they're secondary. And I think if we can really understand how we're doing that and deliver to it, we will be 5, 10, 15 years down the line glad that we have gone down this direction. But it's about inclusivity, patient and family centeredness, and bridging the gap between evidence, knowing that this is going to work or not work, and then putting it into practice. So like Heather, I think this is only part of the data we might need. And I would say really that concentration on the patient and family outcomes is again only part of the data that we might need. There's also the issue of patient and family experience of care. And I would stress to you that outcomes and experience are two different things. They may or may not relate to each other. The PROMS and PREMS group in Oxford, who have done lots of work on this, have done studies in a range of different specialties, and they know that you don't necessarily have good or poor in both directions. So you might have a good experience of care but poor outcomes, or you might have good outcomes but a poor experience. And we need to understand what the difference is between those two. So we're not specifically discussing experience measures here, although we know they need to be understood and captured. So experience measures might be, for example, the modified voices as a post-bereavement survey, or it might be FamCare, administered to families to sort of see what the impression is about that experience of care. Now, we're not really talking about that here, we're talking about the outcome aspect of care. And I want to just stress the Donabedian model, which is that if you approach quality of care, you need to think about the structure, process, and outcomes of care. And most of the effort and energy that we have put into this up until now has been around structure and process measures. So have we got the right sort of team in place? Have we got the right number of beds? Do we have 24/7 care? Do we have telephone access for people to get support at home in the middle of the night? Those are all process measures. Actually, it's the outcomes that we want to get to, which is the difference that's made to a patient's health status and a family's health status. So we need quite a lot of different sorts of data. Patient and demographic data, we might need it for funding and payment and structures and flows and evaluation and research. The bottom line is we need to know the difference we are making for the patient and family health. So there's a lot of confusion about what an outcome measure actually is, and often the word is used in a lay meaning, which is kind of the result of something or the outcome. I remember talking recently in a wider health community about this, and the surgeon in the group said the outcomes is really just about survival and whether your surgery is successful or not. And it's often quite hard to explain to people outside of palliative care that the outcomes we're trying to do are actually quite subtle sometimes. They're quite complicated. They often hang together so that, you know, if somebody's got pain, they may have total pain, physical and psychological and social and existential aspects. You know, it's not so easy to separate them all out. But actually, once you start to understand change in health status or quality of life attributable to the health intervention as the definition of outcome, then you start to understand what it means. Now, I think for palliative care, we must include family health status as well. So the support people get to ensure that they don't have a complicated grief which is not resolved, bereavement follow-up, but also things like family support at the time of caring for somebody, addressing family anxiety and distress, addressing family disordered communication, and all those things. Those are all important. Just to remind you what a quality indicator is, because again there's confusion in the terminology, what's what and what does it mean. And a quality indicator is a norm, a criteria or a standard, a direct qualitative or quantitative measure to determine quality of healthcare. So that's a broad definition, but essentially it has to be explicitly defined, it has to be measurable, it has to reflect one of those components, structure, processes or outcomes, and it has to have a numerator, a denominator and a norm or a standard. And very often you find that people collect data about something. So they might collect data about the number of patients with an improvement in their pain score between admission to a hospice inpatient bed and 48 hours later. It's great to measure that. So you might measure that, but actually you need to know the denominator. What's the total number of people in whom you have scored their pain on admission? And clearly if you only capture 20% of the people coming through the door, then that's not a comparable denominator to other people. And then, what's the norm or the standard that we should apply? And we actually don't know yet, there is no good evidence yet, as to what the normal standards should be. Bearing in mind that actually many of these patients are getting sicker. So it's not appropriate to expect that they'll all improve in their pain scores. We know that. So we need an appropriate norm. Is it 20%? Is it 50%? Is it 60%? Is it 80%? We don't know. And that is where the evidence needs to be built to tell our health masters what is an appropriate norm, so we don't get something imposed which just doesn't make sense. So we have some examples in palliative end-of-life care here. We might have something around symptoms, pain or nausea, shortness of breath, physical symptoms, or psychological symptoms, anxiety, low mood. And really, if you were going to get an outcome, bearing in mind that the definition of outcome is a change in health status, you can only achieve it if you do it at more than one point in time. And that's essential. You cannot measure an outcome at one point in time. Sadly, it would be a lot easier if we could, but we can't. So therefore, we need at least 2 time points to measure the change in health status. We need to capture the relevant domains of need, where need is defined as ability to benefit from a health intervention. And we need to also consider the number, severity, and the interaction of those domains, which is what adds up to complexity. And if we're going to get a quality indicator too, we need the numerator, the denominator, and the norm. So there are lots of very clear, specific definitional issues. We have to be clear we're talking the same language. And we have to measure it at least a second time point to get the outcome. So I hope that is clear, but I'm happy to take questions later. So we need to ask ourselves at what level are the measures being collected and used. And my suggestion is that if they're measured at individual level, we can then aggregate to get a service level picture, to shape and plan services and to help with quality assurance at an organisational level. But we can also aggregate, once we share beyond organisations, to a population level. Either a sample or a complete population, depending on what we think is appropriate, to help understand commissioning and to help with research as well. And then we may also be able to aggregate to national or even international level, similar to the existing minimum data set. But bear in mind, the existing minimum data set is not at patient level. It's aggregated at the service level before it's shared. So the linking of the data is some way in which we can make sure that it works hard for us. And it doesn't just deliver to one thing, but delivers to 5 or 6 different things. And the other thing that's really important, and I would really stress this, is that we can't just use a measure that's thought up on the back of an envelope or derived from what people think is important. There is a whole science of psychometrics. And psychometrics is about how you measure things. And the study of psychometrics is quite, I mean, some people devote their whole careers to it, but it's really important we understand it and we apply it. And we don't just say we can do what we think works on the ground, just because we have to test it. And that's what psychometrics is about, taking what works on the ground and testing it. So it has to be valid, reliable, sensitive to change, and clinically applicable, brief and not too burdensome. So valid means it does what it says on the tin, and there is different types of validity, and I won't go into them, but if you're interested, we can discuss later. Reliable means really that it behaves in the way it's expected to behave. So if you measure it, or I measure it, or somebody else measures it, it'll do the same sort of thing, and if you use it over time, it'll do what's expected. Sensitive to change is critically important in palliative care because our patients are deteriorating. And many of the measures developed outside of palliative care have a floor effect, which essentially means that somebody's getting worse, they get to the bottom of the scale, and they get worse still, but they can't go any lower on the scale. And that's one example of how something may not be appropriately sensitive to change with a measure. And then clinically applicable is really important. If it's not brief and usable, then you might as well not start. And then I would also stress that outcome measures have to work hard for us. They've got to deliver at every level. They've got to make sense to the people using them, the patients, the families, the staff. They've got to actually help improve day-to-day clinical care, because that's the thing that drives most clinicians. And if clinicians are going to help support the capture, they've got to see them working for day-to-day care, even before you get as far as all these other uses we've described. And then they can start to better inform the strategic and management decisions and do all these other things about capturing complexity, delivering to the quality indicators, etc. So, what data do we need? Bottom. There's a bit to wake up if you've been nodding off quietly. What should we capture? What should we start measuring? So we need some demographic data, some basic demographic and clinical data. And I've put a few of the examples up there. There's not that many more, but they're the stuff that we're all collecting all the time anyway, so we don't think these are particularly challenging. Probably age, gender, ethnicity, disease and comorbidity, bearing in mind that many of the frail older people are moving in towards multiple comorbidities. But what do we really need to measure for the outcomes and the quality indicators? So this is the bit that gets contentious. So we clearly need something which reflects patient problem severity. And the difficulty is what problems? What should we measure that really reflects the domains that patients think are important? We probably should capture functional status as well. We should probably capture phase of illness, and I'll tell you why I think that. And we should probably capture family caregiving burden. Okay, so functional status is probably one of the easier ones to capture, and it's important not because we can stop people deteriorating in their function, but because it gives you the wider context of where they are in the journey. Even if the journey is a up and down trajectory of function, as opposed to a steady decline, it still gives you a context of kind of how they are functionally. Phase of illness has been used widely in Australia. There's some papers coming through that have done some of the validity and reliability work on phase of illness, and it captures again something of the context of where somebody is on the journey. And that's quite important, even though people have several phases in each episode of care. So they might become, I don't know if you're familiar with this, and it's in your booklet if you want to look at it, but phases include stable, unstable, deteriorating or dying. Dying is similar to the sort of last few days of life that we used for the Liverpool Care Pathway. Stable means that their care plan is meeting their needs. Unstable means they've got acute or urgent and unexpected problems so that their care plan is not meeting their needs. And deteriorating means they're actually, in an expected way, deteriorating in health, but those things have been anticipated in the care plan. Now, those definitions have been shown to work, and it's one item, and there seems to be a lot of value both in understanding the complexity of people's needs, but also understanding their resource use. So therefore, we think phase of illness is important. But what other problems should we include in terms of reflecting those things that we assess on a day-to-day basis in care? A note before we move on, these are not outcome measures because they've only been captured at one time point. We actually have to have the change, and therefore we must capture them at 2 time points at least to get a change. So we're proposing that for phase of illness, we use the Australian definitions, which I've just described. The functional status, we're proposing the use of the Australian 𝐃𝐎𝐍𝐾𝐘 performance score. And the reason is that it's relatively simple. It goes from 100% to 0 in 10% jumps. Some people have said to us, why don't you use 𝐃𝐘𝐘, which is an oncology measure, which goes 0, 1, 2, 3, 4 in the opposite direction. Now, the reason we don't think we should use 𝐃𝐘𝐘 is that it's not sufficiently discriminatory for palliative care patients. Most palliative patients are 3 and 4 on that scale, and some of them are 2. Occasionally you get somebody who's 1, but it's less usual. And so it actually doesn't discriminate very well between the groups, whereas the 10-item scale of AKPS gives you more discrimination. The other reason is that it has been tested in non-cancer patients quite extensively, and the 𝐃𝐘𝐘 scale has not. So what should we use for problem severity, and what domains should we include? Now, there are lots of measures out there. We've done some systematic reviews of the measures that are out there. One of those systematic reviews showed that there's something like 90-odd measures in use. But there's about 4 or 5 in common use. Okay, and the difficulty is we don't want to end up using 4 measures for problem severity, with bits from each. We want to try and work towards one brief measure that's usable and practical. And if you take that approach, it actually narrows down to a very few. There are things like 𝐸SAS, which is a symptom score, which is a linear analogue scale, and there's FACIT-PAL and various other measures that we could use. We think that you should use something called 𝐈POSS, the Integrated Palliative Outcome Scale. And partly this is our home measure, and we have to acknowledge that, but there are actually very good reasons for using something like this. 𝐈POSS is an integration of POS and POS-S. It's in response to information from patients and families that 2 measures is too much. And it is refined and streamlined to make it as brief and simple as possible. And so it fulfills most of the criteria because there's been 10 to 15 years work on the validity, reliability and sensitivity to change of it. It can still be challenged, and I'm open to people saying, no, we should use another measure. But I would also say, if you say that to me, please tell me what measure we should use instead and give me your reasons, because that is what we need to bottom out. So I don't mind if we go a different direction, but we have to have good reasons to do so. And at the moment, I can see the strongest arguments for 𝐈POSS. And then we have also registered very clearly that family caregiving burden is a really important component of palliative care, which we cannot not address. Now, I would say that that's often assessed at a different time to when the patient is assessed, and that is a really important consideration. But we are suggesting the 𝐒𝐓𝐷 6-item as a valid, reliable, yet brief way to assess family caregiving burden. And if it's assessed at more than 2 points in time, you get an outcome. So that's what we're proposing. It does also have a 1-item version, which is nearly as psychometrically good. And the reason that's important is that when we get to the core national data set, we want to narrow down the number of items. So there may be questions about SCIP about problem severity, and I'm happy to take those at the panel, but we can talk about that later. So you will have got a booklet today, and I'm very glad to say the printers delivered it this morning, so actually got it, which is great. It will also become available electronically, so if you want to download it and use it for your team or whatever. And there is also, it's part of a series of booklets that are coming out, and the first one is also available electronically, which is a general introduction to outcome measures in palliative care, and this is the second booklet. So if you want to go on the website and look for those, you're very welcome, and you can download them electronically. And we want people to use them, so please do download them. I'm not going to go through it all because we don't have time, but it does lay out the different measures, when you might use them, and how to use them. And we certainly have the complete set of measures, and they are all freely available. Some measures have a cost with them, but none of these do. The 𝐈POSS is freely downloadable from the POS website, and the address is in the booklet. I would say that the 𝐈POSS measure comes in different forms according to which setting you're using it in, whether you're asking patients to complete it or staff to complete it, and both are possible. So what is being proposed nationally? And this is very hot off the press because we had a meeting on Wednesday morning with a lot of the national stakeholders to try and understand what might be mandated nationally. And there was a proposed data set put forward, and there was discussion around what should be in it and so forth. Now, there is some demographic information, and there's some spell information, so information about the episode of care. You know, when did it start, when did it stop, that kind of thing. I'm not going to go into those because they're less controversial. I'm just going to talk about the outcome components. So they propose nationally that we should measure these things at 2 time points. Probably at the first time that somebody's seen, and in an inpatient setting 3 to 5 days later. So that would be hospital teams and hospice inpatient teams. And then in the community, the first time somebody's seen, and then 7 to 21 days later. So that's quite a broad range, but it's important because there are different models of community care. And we need to be flexible enough not to change clinical practice, but to try and accommodate clinical practice. What should we measure? Phase of illness and functional status. They're each one item. So it's brief and condensed. And then we should measure problem severity and family burden. And you can imagine that was where all the discussion happened. Which items? But there was consensus, and this is the consensus as far as I understood it. And if anybody was there and wants to say anything different, then shout when we get to the panel. So pain score, I think people were agreed that the pain score would be appropriate, and the 𝐼POS item is appropriate. Breathlessness, because breathlessness often takes people into hospital, and the breathlessness item is appropriate for 𝐼POS and sufficiently discriminatory. Patient anxiety and distress, because it's a core of what we're trying to help with, and that again is appropriate from 𝐼POS. Depressed mood, because depression is important to screen for, and we know this is a good screening question. So again, that's from 𝐼POS. Spiritual and existential and broader distress, there's a question in 𝐼POS now which asks whether people are at peace or not. So that covers a broad, I mean, it's partly physical, partly psychological, partly spiritual and existential. But actually, in practice, patients and families really like that question because it covers all sorts of people, all cultures, all backgrounds, and actually it seems to work. The family burden, there was some discussion about whether we should use the family anxiety question from 𝐼POS for simplicity, or whether we should use something more robust like the 𝐒𝐓𝐔𝐃𝐘 one item. But it's there for discussion. There's 2 items that were proposed at the workshop, 7 and 8, which I'm going to come back to, and 9, which I'm going to come back to. But 10 is who is assessing the pain, the breathlessness, the anxiety, the depression, the spiritual and existential distress. And that's really important. Is it scored by the patient? Is it scored by the patient with help from family? Is it scored by the patient with help from staff? Or is it scored by staff? Because the way the questions work will be different in different groups. Patient's family score pain higher, for example. Staff score some of the less visible symptoms lower. So they score depression, for example, lower. So understanding who's answered the question is quite important. Now, there's a debate about 7, 8 and 9, and I don't know how it's going to go. Some people wanted to be sure we got in something about decision-making involvement. Now, to me, that's part of experience and not an outcome measure. It's important if you feel involved in the decisions that are being made, according to how you want to be involved. But I think, to me, that's part of experience and not outcomes. And that's why I said at the beginning we have to be clear about the definitions, what we're trying to achieve. So I suspect that one will come out, but it may go in. There is actually a measure of this, which is validated, but it hasn't been validated in palliative populations. St Christopher's developed SCIP because they liked bits of POS, but not all of it. And they wanted to add in some other things. So they took some bits of POS. They took a question from the EORTC Quality of Life questionnaire, which was a general quality of life question. And then they added in a question about whether a service was making a difference or not, because they thought those things were important to include, and they wanted to also deal with the issue of response shift. Now, the difficulty with that is that SCIP is not valid or reliable. There's one paper being published in PalMed with 40 patients, but it's not enough to tell us that this is working and it's valid, reliable and sensitive to change. So we've worked closely with St Christopher's on this to work out what are the bits to capture that weren't captured in POS. And we have agreed that 𝐼POS plus an additional module called Views on Care will cover those additional items. And the 2 that were proposed by the national group are those 2 questions which are in Views on Care. So we think we'll be able to get to a place where that's covered. So you've got all those measures in your booklet, and I hope that will help. I'm not going to say why bother, because I think this is being stressed. But I do think winning hearts and minds is part of our job and part of your job. Thank you.